on the radio, social media, and we are getting ready to go live. On the radio, we have Colin, our producer, who's going to be calling the shots. You'll probably hear him. My co-host and I, Dr. John Phillips, we are going to be ready to go live. We're talking about high blood pressure today. We have a great live studio audience. We have, Marie, I'm going to change that name. I can rename you. I have the power.
I can change it back.
I know you can. I love seeing your face, though.
No,
It's
All right,
good.
folks, 10 seconds till we air.
News, information, reassurance. 860 AM, The Answer. Streaming now on smart speakers and the Odyssey app service of Salem Media Group. This is 860 AM, The Answer.
Sponsored by The Way to My Heart Incorporated.
Welcome to the Heart of Innovation. 60 minutes that could save life and limb, with new breakthrough ideas and innovation changing the healthcare landscape. Brought to you by patient advocacy group thewaytomyheart.org in partnership with Abbott. Here are your hosts for the Heart of Innovation, Emmy Award-winning journalist and founder of The Way to My Heart, Kym McNicholas, and interventional cardiologist and founder of the Save My Piggies Health Education Series, Dr. John Phillips.
Hi, everyone, and welcome to the show. It is the perfect day. Dr. John Phillips and I were talking off air just before the show about this being just the perfect day to be sitting inside on our Zoom, talking on the radio, because in one part of the country, it is snowing. In my part of the country on the West Coast, it is storming with lots of rain and wind and some hail in certain areas. So it's a good day to be inside, staying warm, listening to us on the radio.
Yes, and getting ready. We're going to be
watching football.
And watching football. Kym, you're a 49ers fan. I'm a Packers fan. We're going to make this a civil conversation today, but may the best team win.
Yeah, definitely. I don't know. We'll have to see on this one. I'm curious what the odds are on this one. Have you heard?
Yeah, so the 49ers are favored by about 9.5 points. They're a good team. Great offense, stout defense. You know, I'm the eternal optimist with everything in life. Packers have a chance, but they have to have an 8+ game and create some turnovers. So we'll see. We don't fare very well against the 49ers in the last couple playoff runs. So fingers crossed.
I think the Packers, though, are better playing in weather because it's storming here. And I think that we've been pretty spoiled over the last few years here in California, not having too much weather. And in terms of practice, they don't practice that much in the rain out here.
However, you covered sports, right?
I did. I was the first female sports director / sports anchor in the San Francisco Bay Area. And I was the first one to have a racing show.
That's awesome.
And I did sideline reporting for the Pac-12.
Let me ask you this question. Were you ever one of those that had to catch the coach halftime and hey, I need 30-second a clip from you, and the coach wants to get off the field. They're clearly bothered by the fact that they have to talk to a reporter. Was that ever you, trying to? Hey,
it was always me, especially in college. Whether it was Berkeley or Stanford or up at UC Davis, and Arizona was another team. But I always thought they were very kind. They always expected it. But here's what was unexpected for me. I was always told that sideline reporter would have questions fed to them from up there, because you're sitting there on the sidelines. I'm getting updates on injuries. I'm running from one side of the field to the other. I'm not really sitting there watching the game, because I'm having to watch everything else that's going on the sidelines, all the storylines that are on the sidelines. And so when they come to me at halftime, my first game, I was sitting there going, where's the question? So that was a real eye-opening experience for me. But after that, of course, I was really sitting there as I was running around, listening to the commentators call out the plays and things like that. So I was able to be more informed. But yeah, that was a surprise. I was not fed any questions down there as a sideline reporter. It all comes down to us.
Now, see, this is really fascinating to me. Did you know much about football or the sports you covered, or would you okay, I got to read up on this, or is it like you gravitated towards football because you liked football or something?
I was grown up, watching football. My grandmother was a big football fan, so to hang out with my grandmother, I had to sit there and watch football. My brother played football. Both my brothers were into sports. My dad picked off Joe Namath in a high school game. I know, right?
Big Dad, that's awesome. All right.
It's his claim to fame. Um, but and I was a stats girl, so I did stats for all of the different sports teams. So I really knew the plays, I knew the calls and that kind of thing. Where I did need to catch up at that point when I became the sports anchor was really getting to know all of the different storylines in all the different sports. And then one sport that I became really proficient in and ended up with my own racing show was in fact racing, because at the time when I started out as a sports anchor, I racing really wasn't a big deal, even though we had Infineon Raceway at the time, one of two road courses on the NASCAR Next Cup circuit. At least that's what it used to be. Now it's Sonoma Raceway. And I used to go to these press conferences and I would be sitting with maybe one or two other reporters, and all of the NASCAR drivers, from Jeff Gordon to Tony Stewart to Carl Edwards, they were all sitting, we were just sitting at the table with their girlfriends or their wives, just hanging out. So I got to know them really well. And I became very passionate about the sport.
That's awesome. I did not know that about you at all. I knew there was a sports background, but the racing, no clue. Do you go to NASCAR stuff at all, or you still have an
I don't do
interest?
as much anymore. I used to, but now I've become I'm the type of person that when I, get into something, I immerse myself. And so I was
Mhm.
really immersed at the time into every single sport and whatever, but now I'm really immersed into healthcare and spending most of my time going to those conferences, talking to patients, talking with you every week. So that's taking up most of my time, except for watching football with my dad. We do try and catch the games.
So who's dad going to be pulling for today? 49ers
He's
or the
definitely a
Packers?
49ers fan. I mean,
All right.
unless the Steelers are playing, then Steelers, that's our team.
Yeah. Well, that's right, because you guys are from that area, or he was from that area,
Pennsylvania.
right? Yeah. Well, you
Yeah,
know what? I still like your dad, so we'll leave it at that.
but because of you, we always vote for Ohio. We want
That,
Ohio this and Ohio that. So
that's true. That's true. All right.
in college, we're all about Ohio, just
I'll
for you.
I'll take what I can get.
I want you to be in a good mood and be saving those piggies.
I'm in a great mood. Yeah, man, this was a rough week though for us. We had a patient who ended up losing both her legs
What?
because, yeah, it was just, yeah, I was involved in the care a little bit, but she had presented, she had cancer, and then
Oh no.
was getting some treatment, and we think she embolized, meaning clot had formed and blocked arteries in both legs. And because of the cancer treatment, she had some blood work issues that were prohibitive for us to do anything. And then by the time that got better, it was just nothing we could do. And last night she had both her right and left leg amputated. It just, because I helped out to try to restore some blood flow, but it was too late. Sometimes we can get the blood flow back, but if the damage is too profound, the tissue and the skin and muscle and stuff just necrose, and it's
Do you
unfortunate.
find I've been getting a lot, through our nonprofit organization. I've been getting quite a few cancer patients lately, that they ended up having damage from the radiation. Is that something that you see quite a bit with the arteries?
We'll see that in patients that have had like chest wall radiation.
Oh,
You'll
interesting.
see that in the coronary arteries, but not too much in the
Not in
peripheral.
the leg.
No, but people are at risk for clot formation when they have a
Oh, yeah.
malignancy. And so this is something I've never seen, though. I've never seen both legs get knocked out at the level of the knees, and we couldn't even try to open one. We opened the other one, but it was too late. So this was a first for me, and you just take a step back and you wonder what you could have done differently. I don't think we could have done anything differently, but you just feel so bad for the patient and the family, because this is a life-changing experience for sure, in a bad way. So,
In a really bad way, as if she didn't suffer enough, right? With the cancer, and she fought that, and then suddenly to have complications because of that treatment is really sad. And one thing, I know we only have a few seconds left before we go to break, but I think this is an important point. When it comes to blood clots, there's still so much that we don't know. And you can go in there and you poke the beehive with that wire and you could shower clots and just trash the foot. And sometimes, and I think even, what would you say, most of the time going in there when it's a situation with a bunch of fresh clot, it's like going in blind at times. You don't know what you're going to get.
Yeah, you do the best you can. You're prepared for instances like that, but you don't necessarily know what to do a lot of the time. You just kind of make one step forward and just kind of reassess and keep moving. So I guess that's the best we can do.
You can. And I know, and I can see it's really hard on you. And so it's good for patients to see that anytime, they have to amputate it, it's not a good day. It's a bad day for the patient and it's a bad day for the doctor. And it's really sad. So we wish the best to that patient. Hopefully she'll be able to continue and thrive even still. We have plenty of patients that have been able to thrive in a wheelchair and get prosthetics and move forward. And hopefully she's one of them.
Indeed.
Coming up next on the Heart of Innovation, we're going to get into our main topic of the day. I see our guest has arrived. So we're going to be talking about high blood pressure, complications that go along with that, as well as some breakthrough treatments. So stay with us right here on the Heart of Innovation. Don't go away.
Arteries. Be sure to ask your physician.
You just got out in enough time.
Thank
Colin,
you.
we were pushing it, weren't we?
Pushing it is lightly.
But I knew that you would jump in if there was an issue.
Don't worry, you guys got it. Okay, so we're going through this right now. We should have about a minute 30 right now before we get into everything, but I just wanted to get you to those last few seconds. So we'll have that, and then I will get you in right before about 10 seconds.
Sounds good. Hey, Eric, how are you?
Hey, guys. Great. How are you?
Doing well. Thanks for joining us.
Absolutely. I'm thrilled to be here, and I'm glad the timing worked out. John never know what's going to happen today. So I went in first thing in the morning, and hopefully that bought me a few hours. So
now, are you on STEMI call as well, or?
Yeah, everything. I always just package it. So I take a lot of vascular call because we don't have a large group, but then I have STEMI call every 4 to 6 weeks. So
okay.
Yeah.
Well, yeah. I mean, Kym knows there's been plenty of times where we'll do this live and I'm on call and I'll be like, all right, Kym, I got to go.
It's all you.
He'll shove into a case and then he'll come out like at 5 minutes till and we're like, and he'll call us and he'll say, so how'd the case go? And he'll be like, I saved the piggies.
Yeah.
That's awesome.
Yeah, it's good. Well, how you been?
Good. I'm everything's great. Been busy, but great. How about you?
Just not, living the dream. I saw there was an email from Cook yesterday.
All right, folks, 10 seconds till we air.
Hey, John, you want to introduce your buddy over there?
Indeed.
So Secemsky, just to remind, I know everybody gets my last name.
Secemsky, right?
There it is.
This is 860 AM. The Answer.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody, and thank you for joining us. Kym, I think we're going to get into the meat of our conversation. We spent the first segment talking about sports. I'm a Packers fan. You're a 49ers fan. Our guest and my friend, Dr. Eric Secemsky, is actually a Bears fan, I heard. So, licking his wounds maybe, but we'll see.
Licking his paws.
We're waiting for a moment, man. We're waiting for a moment. So it'll come.
Hey, you got to believe. But yeah, so Kym, you wanted to have a conversation about hypertension. And, Eric and I see folks that have hypertension. I know Eric's going to talk to us about his hypertension clinic at the Brigham, right? And
Beth Israel.
Or is it Beth Israel? Beth
there
Israel.
You go. Right across the street. Yep.
Right across the street. A lot of folks have hypertension. It goes untreated. And sometimes we do an inspirational quote, and we don't necessarily need to do the hoopla about it, but I have a quote from Vince Lombardi, and I think it's germane with respect to hypertension treatment. And so Vince Lombardi is quoted as saying, individual commitment to a group effort is what makes a team work, a company work, society work, and a civilization work. So we sometimes, and I'm guilty of this, I see a patient who has hypertension in the office, and I say, you know what, you probably talk to your primary care doctor about that. And then I imagine that that patient goes to the primary care doctor, and the primary care doctor says, you probably talk to your cardiologist about that. We kind of pass the buck, but that's an individual who we need to work and commit to helping in a group effort. And so I'm really excited to have this conversation. I know Eric is going to talk about a new treatment that just got FDA approved that hopefully can help patients with hypertension. So Kym, let's kick it off and let's discuss hypertension for the next, 35 minutes or so.
Right. And Eric, the reason that I brought this forward is because I don't know if you know that my mom transitioned. It's still something that's so surreal for me every single day. I know we're almost 2 years later. I can't believe it because she was my best friend. And now I just every day play back in my mind all of her healthcare history and all of the things that were brushed off and trying to put together timeline after timeline. And one of the things that I remember way back when is her being on blood pressure medications. And the doctor saying, well, it's not because I think you typically have high blood pressure overall, but you have this white coat syndrome. And if you have this white coat syndrome when you're here and you have high blood pressure, well, it's likely if you have 10 times at home that your blood pressure goes up. So let's just put you on high blood pressure medication. No big deal. Nothing else you need to do. As if it was just an everyday thing. No discussion about what might be causing overall the high blood pressure. Is there something going on with your kidneys? Looking back into her charts, well, she had, stage 2 kidney, chronic kidney disease, and maybe that played a role. I don't know. And then suddenly, fast forward, her blood pressure became erratic, and she was gone within 2 months from a dissected aneurysm. And so it's like, whoa, wait a minute. And I just hear this all the time. Oh, you have high blood pressure. So can you just kind of dial us back and start from the very beginning and explain what is high blood pressure? What are some of the different causes? And we'll get into some of the treatments as well. And oh, by the way, why are you so passionate about it?
Wonderful. Well, yeah, so thrilled to be on the show. Trying to love that quote. And Kym, we've talked about, your loss before, and I know it's still, present every day. And so, what you're doing is wonderful to bring awareness to all conditions from PAD, but also everything that influences PAD. And, we talk a lot about, as an interventional cardiologist, both John and I, and vascular surgeon, interventional radiologist, about all these treatment algorithms. We're going to cross a blockage. We're going to put a stent in. We're going to save someone's leg. But we often forget that this process was, if not avoidable, at least something that could have been slowed if we had gone back 20 years and done a lot of the interventions that don't really get done to most patients in the US, which is controlling these modifiable risk factors, getting people off tobacco, putting them on cholesterol medication, and really importantly, controlling blood pressure. And so, I became passionate about this about 3 or 4 years ago. And similar to what John shared about his own clinical experience, when you're in a cardiovascular clinic, we get patients who come in and they've just had a heart attack, they have heart failure, they have arrhythmias that are uncontrolled. And the list is so long that when you see an elevated blood pressure read, it's probably 5th or 6th on your list in a 15 to 20 minute visit. And you punt it down the line. You say, well, let's check it at home, send me a blood pressure read, talk to your primary care doctor. And so what I observed in our own practices, I've been in several hospitals across Boston, San Francisco, and Chicago now, is, we really need a dedicated physicians and a center to really do the best for our patients. And if you step back and look at the numbers, 1 out of every 2 people in the US has high blood pressure. One out of every 2 people. So this isn't, you walk in the mall and maybe one person in the mall has this condition. It's everywhere you turn. And so it's also been labeled the silent killer for a reason, because the hard part with the high blood pressure is the majority of people do not know they have it. We very infrequently, develop symptoms early on in the process of high blood pressure. So we could be walking around for years, decades with high blood pressure that's uncontrolled if we've not had any opportunity to see a primary care doctor, get our blood pressure read, been willing to follow up. There's a lot of really opportunities to intervene that are lost because It doesn't cause symptoms. And, we often have other conditions that take precedence. And so that was really where my passion around this has come. And high blood pressure for everybody out there is really when the flow of blood down your blood vessels is going at a higher pressure than is safe for our organs. So if you think about turning on a faucet and the water flying out and spraying all over, that is, high flow. That can cause high pressure. And if you put something in front of it, like a thin piece of glass, you can fracture it. In the body, when there's high flow, high pressure like that, a lot of our organs are sensitive to this. In particular, our brains, our hearts, our kidneys. These organs don't like that pressure pushing up against the small vessels, pushing up against the pumping heart, and it causes problems over time. It can cause dissections and aneurysms in the brain. It can cause thickening of the heart muscle, weakening of the heart, and holding on to fluid. And it can cause pressure on the kidneys to the point that the kidneys start to scar and fail. And Kym, you kind of mentioned this as well. And so we see this across our patients. Unfortunately, some of our most vulnerable patients, those who have a minority race background, those who are underserved or live in poor areas, have higher prevalences of this. And there's some probably genetics to that, but also some of our environment where there's more processed foods, less fresh foods, and other environmental factors that are making this condition even worse for our most vulnerable patients.
And coming up right here on the Heart of Innovation, we're going to get more into the heart of high blood pressure and some treatment options. So stay with us right here on the Heart of Innovation. Don't go away.
3 years ago, my symptoms started with leg pain and leg cramps.
Everybody clear?
Me too, with a tightness in my
Thanks, Colin.
Awesome. Well done.
Yeah, that was great.
Oh, good. Yeah, thank you. I was trying to read your cues. I saw your face, Kym, so I was like, okay, I think I have
If we do like this,
yeah,
that means
perfect.
30 seconds or so. But yeah, no, this is a great conversation. Eric, I'd like to, how would you like to do the next segment? Because we have a lot of patients that listen to this. And part of what I'd like to explore is the patient's experience in their doctor's office when the blood pressure is elevated. So do you mind if I ask you, like, hey, Mrs. Smith, or blood pressure is this, how do you work that up? This whole, I never got the white coat syndrome thing because, yeah, I personally, I don't put a lot of stock in a single reading, but if your blood pressure is high when you're seeing me, maybe you're stressed out. I get a lot. Well, the traffic was bad. I'm like, well, there's
of course. I ran from the garage.
Right.
Yeah, we'll get that all the time.
But so maybe, and Kym and I were talking about this before. Stress at home can then cause your blood pressure to go up. So yeah, I mean, I think that'd be kind of fun to talk about that. And obviously, we've got to get to your clinic because I'm interested in that.
What should these patients be asking when the doctor says, "Oh, you have high blood pressure"? It's like, okay, well, I'll just take a pill. But should you ask more questions to get to the heart of it? Is it just stress? What do you think is causing it? Is a pill really going to just solve the problem?
Apologies for interrupting. Just want to give you guys some producer bits right here, right now. So we have about a minute and 30 before we're back on air. And also, Kym, Dr. John, because the usual segment of the medical notepad is not in, I can be flexible with the segments. Both of them are about 10 minutes, but you don't have to be exact on anything. So if you want to finish an idea, that's fine, but just letting you know.
Thank you, Colin.
Thank you, sir. Colin's a Ravens fan, so he's really happy right now. I think the Ravens are going to do pretty well.
Hey, when I heard Miss McNicholas was a Steelers fan, I was like, this is my job. Don't say nothing. Don't do nothing.
Hold my judgment.
So, Eric, Joe,
that's perfect, John.
Yeah, okay. Joe Campbell texted me. He's like, yeah, make sure you ask Eric about the Bears. I said, all right.
Yeah, Joe and I share I'm a Cubs fan also, so finally I got that one knocked off, but that was a painful few decades.
Well, I grew up just outside of Milwaukee, so for a long time, the Cubs fans would populate the county stadium and Miller Park more so than the Brewers fans, and that always irritated people.
Oh, I've been there before. Trust me. And
I suppose. Yeah. But I'll tell you one thing. There's something like being at Wrigley and in the bathrooms in that trough. You're like, okay.
I got a little son. I was like, I got to take, it's an experience, that whole park,
Yeah, that's awesome.
Yeah, it's awesome.
So yeah, we'll just take it back. We'll take it from a patient point of view.
I'll probably shorten my answers a little bit just to keep you prompting me on where you want to go with the conversation. So
that's fine.
I'm easy. So
all right, folks, we're getting ready. 10 seconds till we air.
Firm offers insurance services. Investment advisory services offered through Heckman Financial and Insurance Services, Inc. Investing involves risk, including the potential loss of principal.
860 AM, The Answer.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Thanks for joining us. We're continuing our conversation with Dr. Eric Secemsky, interventional cardiologist out of Beth Israel in Boston. We've just started to kind of touch on hypertension, and during the break, Eric and I and Kym, we were kind of discussing like, hey, let's take hypertension from the patient's point of view. And so, Eric, pretend you're seeing me in the office, and I get checked in. My blood pressure is 145/80. And, you're going to talk to me about my other health issues. I've had a heart attack, et cetera, and presumably I'm on the right medications. But, let's say you forget to mention it. And I say, Dr. Secemsky, what do you think about my blood pressure? What should I do here? What are your thoughts?
Yeah, that's a wonderful, question and really important for everybody out there to think about. What is the right questions to ask, and how do I interact with my physician, my doctor, my clinician about managing my blood pressure when I do get an elevated read? So, I think one thing that, we've all seen when we're in the office with our patients is it's never easy to get to your doctor's office and into the room. And so we all know that we're often rushing and trying to find parking and trying to run up the stairs or up the elevator to get to the office room, and then we get a blood pressure read that's elevated. And so what is elevated? First, usually that means that the top number, which we call the systolic blood pressure, SBP, the top number is over 135, or the bottom number, which is called the diastolic blood pressure, DPP, is over 90, usually over 80, but 90. And so, once you start to get reads that are over 135/80, then, we know that can be an elevated blood pressure reading. And it can always be triggered by events, whether it's stress. When we exercise, we know our blood pressure goes up. So we know that there are some triggers. But when you go to see your doctor, I don't think it's really enough to say or have that conversation with the physician that, oh, I rushed in here and that's why my blood pressure is elevated. Because we need a little bit more data. We need to understand a little bit more. And so one of the first questions I ask my patients are, have you checked your blood pressure at home? And if so, what are the normal numbers that you're getting? And if they say, no, I haven't, and even if they say, yes, I do, I usually check it again a little further into our appointment, because then we have a little bit of time for everyone to settle in and just see if we're getting the same measurement again. And I think one thing with blood pressure, just like our body's day-to-day, functioning, is it's dynamic. It's changing based on our activities and whatnot. But even these single measurements give us some insight that maybe that patient's blood pressure has been running high and hasn't been seen. And so step one is really confirming that blood pressure read is accurate. And again, rechecking it in the office, confirming what blood pressure reads look like at home if you do have a blood pressure cuff, or looking at some of the other visits they've had with other doctors recently can give you some perspective on that.
What are some, go ahead, Kym.
Well, I was just curious. So what I was told is that if you do have high blood pressure, when you first go in the first read, they do it 3 times is standard, once in the middle and then once at the end, correct?
Yeah, so there's a couple of different approaches for that reason. And again, everybody's triggers can be different, but some machines actually, and then my primary care physician does this for me when I'm their patient, is it will actually, the nurse and the physician will step out of the room. And so they'll kind of put me in the patient room with a machine, and they'll check my blood pressure 3 or 4 times over 5 minutes. And what that typically does is allow our bodies just to accommodate sitting down and relaxing, and then trying to get a more accurate read. But I think very other reasonable approach, Kym, like you mentioned, is even if that they don't have that type of machine or do that approach, is checking again later in the visit, either in the middle or in the end, just to get a confirmatory number to move forward with next steps.
So why is it that 1 in 2 American adults have high blood pressure? I mean, that's just, it can't just be, is it the stress? Do they have any research on this?
Yeah, I mean, there's a lot of data on this. You know, much of this is our body's adjustment to really an industrialized world. You know, when our bodies were first made, it wasn't with the same exposures that we have in our life today. And so a lot of this is really explained by multiple factors. So there are some components of this that can be genetic. There are some types of high blood pressure that can be caused by other conditions. But the majority of people have what we call essential hypertension, which means it is really high blood pressure that everyone, there isn't necessarily a causative issue. It's more of the environment plus our genetics. And if you think about what causes blood pressure to go up, it's the things that really plague us every day, all our vices. It's being overweight, it's being sedentary, it's drinking too much alcohol. These are all the factors that increase our blood pressure, and really is what in part is driving a lot of this prevalence higher, is that we have really seen the obesity epidemic take its toll, and that has caused a lot of people to have poorly controlled blood pressure. We eat a lot of food that's processed with salt and other factors that can raise our blood pressure. So, you know, there is a lot that is around us that's influencing this. But I will say there is still a genetic component and some secondary causes.
So if we go back to the patient who you see has a blood pressure is 145, whatever it is, it's elevated. And the patient asks you, okay, well, what can I do to get that number lower without having to take medication? What's the first thing you're going to tell them?
Yeah. So there's a couple ways I think about it. First is, what are their other medical problems and how high risk they are? So if that patient came in and they had a recent stroke or a recent heart attack, I want to move a little faster and I want to be a little bit more aggressive. But most people who come in and have a diagnosis of high blood pressure or hypertension are usually young, and that might be their only problem. That's what happened to me when I was in my late 20s and early 30s. And there are things that we can do to lower blood pressure. And again, it goes back to what I just mentioned, all the things that we did to cause our blood pressure to be elevated. We know that weight loss, several pounds of weight loss can drop your blood pressure by 5 to 10 points. Being active can really be effective at reducing our blood pressure. Limiting our alcohol intake to what's recommended 1 to 2 drinks a day really can also help make modifications to our blood pressure. And then some people, not everyone, but some people are really sensitive to salt. And so lowering salt and even increasing potassium intake, like through bananas and other foods, can also help lower our blood pressure without needing a pill.
Well, coming up here on the Heart of Innovation, we're going to find out what his clinic is doing to actually treat not only general high blood pressure, but also that hard to treat high blood pressure. They have a breakthrough treatment you won't want to miss. So stay with us right here on the Heart of Innovation. Don't go away.
We all know that aches and pains come with simply
clear. We have about 2 minutes till we come back on air. Also, with the next session, when we come back, we'll have 11 minutes.
Oh, good. That'll give us plenty of time
music to our ears.
Yes, talk about your clinic, and then because that's our second to last segment, right? Then
that is
okay. So let's get into the clinic and then renal artery. I'm assuming we're talking denervation. Yeah.
Denervation, cool. Yeah.
Perfect.
And I'm curious how you discovered that. And who's doing it? Are you guys the only ones doing it?
Well, no, there's sites starting to roll out across the U.S. now. It got approved in kind of mid-February. There's 2 devices now approved. And so the main struggle right now has been really the reimbursement side. It's hard. There's no reimbursement for the catheter. So everybody has to kind of individualize how they can approach that. But I've done, I think, 8 or 9 cases. I did one yesterday. I have a whole queue of patients waiting. And so we've been in some of the trials recently. So it's definitely
we're gonna have
move.
to talk offline about how to get this rolling, because I know Joe's probably reached out to you about our. So we used to have a hypertension clinic sponsored by our health system that was staffed by nephrologists, and then I don't know what happened, but they ended up pulling the funding on it, and then our nephrologist left, and so we don't have a hypertension clinic. And I think, my goal would be to create a like not necessarily hypertension alone, but maybe a preventative cardiology clinic that deals with hypertension too. It's a big lift for us, so I'm curious to chat with you about that.
Yeah, maybe I'll make a comment about it, because I started about 2 or 3 years ago, kind of serendipitously with an interested, fellow I have.
Everyone, just to let you know, 10 seconds till we air.
So I can dig into it, and then we can always talk offline also.
Space program. This is SRN News.
8:60 a.m. The Answer.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Welcome back, everybody. Let's get back into this discussion. So, Eric, riddle me this. We talked about it. We've got almost half of Americans have hypertension. It's a disease that we not necessarily don't know why people have it. We talked about the essential component of it. People are living longer. Their arteries aren't as compliant as they used to. But let's put that aside. So this is a disease. Half Americans have it. We're doing a terrible job of controlling it. I'm looking at the CDC website, and it says half of adults with uncontrolled high blood pressures have readings of over 150. That's about 37 million Americans. So we're doing a terrible job, but we can prevent this. So you guys took it upon yourselves to start a hypertension clinic. Tell us the genesis behind that and how that led to your involvement in a breakthrough therapy. We were doing it before, and we can, I guess, maybe get into the trial, and that wasn't positive, but now the trial for renal denervation looked good. So now we're going to potentially have another treatment option. So there's hope on the horizon, I guess is what I'm trying to say. Would you agree with that?
Yeah, absolutely. I think, one thing we haven't talked about is the good thing about high blood pressure is there's a lot of therapies out there. We all know what blood pressure agents are. We've probably either taken them ourselves or have a loved one, a parent, a grandparent who's on a blood pressure agent. And over the last 30, 40 years, there's been a number of different classes and blood pressure medications developed. So that sounds great. The problem with blood pressure medications, though, is everybody's body responds to them differently. And so some people can have a little effect or a larger effect from a blood pressure med. Some people can have a really bad intolerance. They can feel less energetic. They can get headaches. They can get swelling in their legs. And so when you step back and look at all those patients who have high blood pressure, who should be managed, and getting to those blood pressure readings of less than 135/80. As you mentioned, John, more than 50% are not reaching that. And a big part of this is being adherent to the medications prescribed. If you look across different studies, more than 40% of people who were prescribed blood pressure medications were not taking them consistently. And it's not that these are bad patients or bad people. These are challenging regimens. They can be pills that need to be taken 1, 2, or 3 times a day. They're pills that are dependent on you taking them every day. And when you miss a day, your blood pressure shoots up. And if you look at the number of meds, if you go from being on 2 blood pressure meds to 3 blood pressure meds, you're twice as likely to not be able to adhere to that regimen. About, again, 40% of people at that point when they're on 3 meds can't take them every day, even though they're trying. And if you go up to 5 meds, it's well over 50%. So, John, to your question, we recognize this in our own day-to-day. You ask your patients. Occasionally we've had pharmacists do pill counts, and there's a pile of pills at the end of the month. And the patient said, I'm trying so hard, but that one day I wasn't feeling well. The next day, I was out of town and I forgot my pills. And, and some people, again, I just can't tolerate this medication. And so 2 things really need to happen. One is these patients needed a place that we're walking them through more regularly, a protocol, an algorithm to find the right meds that might work for them. And then 2 is a pathway to really bring in new technology so that we have alternative treatment options for blood pressure. They're not reliant on taking a pill. And so about 3 years ago, renal denervation, as John kind of presented, was this kind of breakthrough procedure we've been talking about for 10 years. It's a minimally invasive procedure. You come in the morning. It's just like if you had an angiogram or a heart cath that John and I do on a daily basis. But in this procedure, you actually thread a wire and a catheter into the kidney arteries in both of them, and you apply some energy, some heat. And that heat will shut down these overactive nerves, these nerves that can be increasing blood pressure, in particular in certain people, to a higher extreme. And it's been a long journey trying to get these devices approved. Their effect are good. They can lower blood pressure by about 10 points, but it's not something that's easy when you look at a group of people, because everybody responds a little bit differently. And so some of the early studies were not supporting that this is better than a procedure that had we call sham procedure, no effect. But more recently, there's been 6 trials that showed this benefit. 6 trials that were designed a little bit differently and some newer technology. And finally, in November of 2023, 2 devices were approved by the FDA and now commercially available. So 3 years ago, we recognized that we're having a problem managing our patients' blood pressure. And a couple of things as we looked at it from a cardiovascular group was we have to own this condition. We're cardiologists, we're vascular doctors, we're dealing with the end effects of high blood pressure, heart attacks and limbs being lost and really uncontrolled, heart failure. And so we need to do a better job, and we needed to offer therapies as they come along and have a pathway to introduce them to our patients. And so I was really fortunate. I had a fantastic fellow named Anna Krawis. She's a cardiologist. She trained in vascular medicine with me. And she kind of got turned on, as I was, to high blood pressure. And we sent her off to get a hypertension certification. And we had a primary care doctor who'd been doing fantastic things in high blood pressure as well, named Jennifer Cluett. And together we formed a complex hypertension clinic. We started this within our cardiovascular division. We got some buy-in from our institution. And the whole charge of that clinic is anybody. It doesn't matter if you are on 0 to 1 meds or 5 to 10 meds. Anybody in any stage of their high blood pressure has a home, had a place where they can interact with a physician, have nurse follow-up, have pharmacists follow-up. And what we do is really work through finding the right regimen for that patient, because we recognize that regimen can be different. Blood pressure medication regimen, lifestyle regimen, whatever it might be, we can find that right regimen for that patient. And now that we have this new technology, this device that can lower blood pressure in patients who have challenges with control, we're able to really bring that conversation forward and introduce that technology. And we've been doing these procedures now since November.
But how many of these, 1 in 2, right, in the US that have this high blood pressure, how many of them have high blood pressure that is triggered by these overactive nerves that ultimately could be treated through this RDN program?
Exactly. Yeah. RDN is the abbreviation for renal denervation. And, the theory here is for anybody with high blood pressure, these nerves are contributing to some degree. And so we know from the trials that in some patients, the nerves, when we shut them down with this catheter, may cause a modest blood pressure reduction, 5 or 8 points. But if you also look at the data, there are people who have a 25-point blood pressure reduction. So everybody's body. Yeah, John, please.
Just real quick. Correct me if I'm wrong, but even a drop in 5% reduces your cardiovascular risk, doesn't it? I mean, it may be 10% reduction. So that's a big number. I mean, 5 isn't huge, but it translates into something potentially very beneficial for the patient, right?
I think me and you are in tune right now. That's exactly right. When you get even a 5-point blood pressure reduction, as in a persistent, you want it every day for as long as possible, you can get a 10%, like you said, reduction in major cardiovascular events. And that's including stroke, heart failure, heart disease, even cardiovascular death. And so I always say every point counts. That's been my motto. And so I think with this therapy, we don't necessarily look for people who have hyperactive nerves. we look more to see if people are really struggling with the control, finding the right blood pressure agents, and need to look for alternative therapies. And then we apply this to really, procedure, hoping that they get the response on the higher end. And we've seen a lot of great results so far.
Are people coming out of the woodwork to be in your clinic? I imagine it's booked to the gills.
Yeah, we're really busy. And, patients are referring themselves, but doctors also, just like us, John, who say, listen, we just don't have the bandwidth and we want the best for our patients. So it's best to have our colleagues be able to contribute to their care. And we have a center to really do that. And so that's exactly right. It's been a wonderful asset for our hospital system.
I would imagine it would be really difficult because right now there are so many shortages and everyone in the healthcare system is so tapped. How did you convince Beth Israel to allocate these resources simply to this particular clinic? They must have seen an overall benefit and cost reduction actually along with it, and patient outcome benefit.
Yeah, I think, again, when you have to go to administrators to make a case for something that potentially could be, not the most financially solvent, we take a look at the big picture. We say, listen, we're going to do something that not many centers are doing. We're going to have our center have wonderful blood pressure control for our patients, which is going to translate into better outcomes. And we're going to attract people from, all over the country who want to be part of a system like this. And so I think that's the vision that you have to feel comfortable working with the administrators on. And the most important part is you got to follow through. And that's, always been my message is, it's easy to talk, but, you got to make things happen. And then things really grow.
Coming up right here on the Heart of Innovation, we'll have more with Eric Secemsky and high blood pressure treatment. So stay with us right here on 860 AM, The Answer.
This is Dennis Prager. Now you can listen to my show when it's
Everybody's clear. We have 1 minute till we come back on air.
Excellent timing, Kym. That was a fantastic tradition. I mean, Kym is Emmy Award-winning.
I know she is.
That's right.
Phenomenal.
Well, I'm just a simple plumber. So, Eric, we've got like 4 minutes left. I know you're a data guy, population health. So I imagine you have some numbers that say what you're doing works and is beneficial. I'd love for you to share that, and then just some final thoughts on where do you think hypertension management is going in the next 5 to 10 years? Do you think renal denervation is the end, or are there other potential interventions?
Yeah.
Hate to cut everybody off, but we got 10 seconds till we air.
Start earning money today. Visit Providence.
Eric, if you have a few minutes afterwards,
insured by the NCUA. Rate effective October 18th, 2022, and may change at any time. Other terms and conditions apply.
This is 860 AM. The Answer.
Welcome back to the Heart of Innovation. For more on today's topic, go to theheartofinnovation.org. That's theheartofinnovation.org. Once again, here's Emmy Award-winning journalist Kym McNicholas and interventional cardiologist Dr. John Phillips.
Continuing with our football theme, we're into 2-minute warning here. Go Pack. So we're rounding the show up here. Eric, you are a numbers guy. You do a lot of work with population health. You get a lot of data for us in the interventional world. I imagine you've looked at your data with respect to your team's ability to control blood pressure and that in the community. What numbers are you seeing, or what are you seeing?
Yeah, I think we're having fantastic outcomes. I would say that the majority, I would say over 75% of our patients who have seen us are now reaching their blood pressure goals through a number of visits. It usually takes 3 to 4 visits for us to really find the right combination therapies. But we really are making a mark in terms of how patients are being able to manage this condition. But, I think also most importantly, it's just patients feeling like they have a home to present to with these problems. Again, things come up all the time with our patients who have high blood pressure. And so we're a resource to them. And I think that we are aiming for control, but aiming also to be an asset for their overall care.
What role do insurance protocols play? Because I know, for example, if you have, high acidity in your stomach and they need to put you on a Prilosec or, any one of the other ones, they have this line, depending on insurance, is you try this first, you try this second, you try this third, or else we're not going to cover it. You can't jump from 1 to 4, right? Do you feel that same pressure when it comes to blood pressure?
That's a great question. The one nice thing about blood pressure agents are they're made very cheap. The older ones have been around a long time. So the average person could get a very good regimen of blood pressure agents for a very affordable amount of money. And you could get like the Walmart or Amazon pricing there. But the one thing that we have seen in a number of trials are these combination pills. If you actually take 2 or 3 different types of blood pressure medications and put them in a pill, you are more likely to take that pill and actually can get better control of your blood pressure. Those, though, tend to be challenging to get coverage for from the insurance companies. And so if anywhere, we've seen some struggle with the ability to cover the pills. The procedure we were talking about also is brand new and groundbreaking. And so that also we've had some trouble with insurance as it launches, but that hopefully will be better in the mid-year of this year when we have a little bit clearer coverage for that.
What if people want this procedure and think that it's right for them? What are the indications that this procedure might be right for you, and how do these patients actually access it if they're not in Boston and being able to go to your clinic at Beth Israel?
Yeah, well, I invite anybody from anywhere to come visit us, and we'll make it comfortable. Just don't come in the peak of winter. We're dealing with some cold weather right now. But I think this is just launched. Again, November was with the approval to this therapy. And the nice thing that the FDA did was we weren't sure what the labeling it was going to be, but they've really created a broad indication. So if you have high blood pressure that's not controlled, you're technically a candidate for this procedure. Now, ideally, in our practice, we want people to fail blood pressure meds because in the end of the day, if we can find a good regimen for you with blood pressure agents, I think that's preferable over the long term. But if we are struggling to get you on the right agents, if you're having intolerances to those agents, then really this procedure is a great option for patients to explore. Going online is a little challenging. We're working on getting set up to identify sites that are offering this. The 2 companies that produce the device, one's called ReCor, RECOR. The other one's called Medtronic. I think they have resources on their websites to identify providers doing these procedures.
And we actually at Riverside are participating. My partner, Joe Campbell, good friend of ours, is leading the charge. So we're looking forward to it. Exciting stuff.
Absolutely.
Thanks so much, Eric, for joining us. We really appreciate it. Have a great weekend, everyone.
You're clear on that side. I just need to let it play out. I'll mute myself.